Hello, everyone. My name is Dr. Haemolytic. I'm a hematologist and clinical investigator at Massachusetts General Hospital and Harvard Medical School in Boston.
Hello, I'm Carl Lander. I am a patient with PK deficiency. I am a director with the Thrive with PK Deficiency Foundation in the US, and also I do some work with various organisations in this country, in England. Good to meet this afternoon, and I guess some of it's early morning and some of it's later in the evening, so it's really good to see you. Thank you.
Yes, so regardless of what time of the day it is for you, we welcome you to the Building Best Practices in the Inherited Hemolytic Anemias Community Pyruvate Kinase Deficiency, then, now, and the future symposium being hosted by the Thalassemia International Federation. So Carl and I will serve as your chairs for this session. I'll go ahead and give the first talk regarding essentially a 60-year history of pyruvate kinase deficiency and advances from the time of initial discovery of the disease back in the 1960s up until now. Hello, everyone. My name is Haemolytic, and I'm a classical hematologist and clinical investigator at the Massachusetts General Hospital and Harvard Medical School in Boston. It's my great pleasure today to serve as one of your chairpersons for this Pyruvate Kinase Deficiency Symposium being hosted by Thalassemia International Federation. I'm going to go ahead and get things started with my talk titled 60 Years Since the First Documented Case, Advances in Understanding, Diagnosis, and Treatment of Pyruvate Kinase Deficiency. Here are my disclosures. So in order to talk about pyruvate kinase deficiency, we should start by saying a little bit about the pyruvate kinase enzyme. I don't want to get too technical or into the weeds here, but just briefly, the pyruvate kinase enzyme is the final step in the Embden-Meyerhof glycolytic pathway. It is encoded for on the PKLR gene. The PKLR gene has two products, PKL for pyruvate kinase liver and PKR for pyruvate kinase erythrocyte. And of course, we're going to be focusing our discussion today on PKR. This image here is a figure showing the homotetramer enzyme itself. So pyruvate kinase is really critical in red cell energy production. Under normal circumstances, the glycolytic pathway produces 2 moles of ATP per mole of glucose. Now, this is the only means for red cells to produce energy, as they cannot undergo oxidative phosphorylation and do not have any potential for aerobic energy production, aerobic respiration. In patients with pyruvate kinase deficiency, we knock out a critical source of energy of ATP produced by red cells. And so we get a deficiency of critical ATP that results in chronic hemolysis. So as a hereditary disorder, patients with PK deficiency have mutations in the PKLR gene. This is an autosomal recessive disease. And so patients with the disease have mutations in both copies of their PKLR gene. Mutations in PKLR result in reduced PK activity and PK stability. The enzyme does not last nearly as long as a normal PK enzyme would in many cases. Patients have inefficient glycolysis in the red cell, reduced ATP generation, which leads to reduced red cell membrane integrity. The red cells are less able to maintain their membranes. This results in increased red cell destruction, a shortened red cell lifespan, and chronic hemolytic anemia. Chronic hemolysis, of course, leads to a number of downstream consequences, which I'll briefly touch on. In terms of the most basic, we have anemia, we have hyperbilirubinemia, we have iron overload, and these all lead to acute long-term comorbidities and complications. So the title of the talk is 60 Years Since the First Case, so I wouldn't be doing it justice if I didn't very briefly mention Dr. Tanaka's seminal Blood paper in which pyruvate kinase deficiency was first described as a subgroup of hereditary non-spherocytic hemolytic anemia. So the epidemiology of pyruvate kinase deficiency, this is something that we're still working out. We recognize it as the most common cause of chronic congenital non-spherocytic hemolytic anemia. There have been studies showing a heterozygote frequency of 1% in whites, 2.4% in African Americans based on cord blood samples. The prevalence is still really being worked out, but is thought to be somewhere between 1 in 100,000 and 1 in 300,000 persons, certainly more in certain parts of the world. Specific mutations recurring in certain communities have suggested a founder effect. For example, there is a very classic mutation in the Pennsylvania Amish in the United States. So, in order to understand the phenotypic heterogeneity of pyruvate kinase deficiency, one just has to look back to Tanaka's seminal Blood paper. So I always like, showing this slide. I love these vintage tables. But, if you take a look at the summary of clinical history, we have everything from diagnosis of hemolytic anemia at age 21 as an incidental finding while in the U.S. Army, transfused only 1 unit at the time of splenectomy, leads an active life, all the way to anemic since birth, over 150 transfusions, mostly in the last 10 years, severe headaches, primary problem at this point. So if you take a look at each of these, it really very nicely demonstrates the really dramatic spectrum of disease that we can see in patients with pyruvate kinase deficiency, everything from asymptomatic and only incidentally discovered because a family member was diagnosed, for example, or the patient developed a viral illness or some stressor that resulted in increased hemolysis and a reduced hemoglobin, that all the way to transfusion dependency since birth and throughout life. If you take a look at the PK enzyme activity described in Tanaka's paper, you can see a mean, that is about double the mean in normal subjects, about double that seen in heterozygotes, and then significantly reduced levels seen in patients with the disease. Now, I'll get to diagnosis and the value of PK enzyme assays a little bit later in the talk, but suffice it to say that there is a dramatic degree of variation in patients with PK deficiency, and it's very commonly noted that the degree of enzyme activity, the severity of the deficiency does not necessarily correlate with the severity of the clinical disease. So the genetics of PK deficiency are extraordinarily complex. This is an extremely genetically heterogeneous disorder. There are more than 350 known mutations in PKLR. This number just rises by the year. Most patients with PK deficiency, therefore, are compound heterozygotes with 2 different mutations. The type of mutation does have prognostic and therapeutic importance. Over 70% of patients with PK deficiency, over 70% of mutations in patients with PK deficiency are missense mutations. And the remainder are other types of mutations, such as nonsense mutations, indels and such. And we'll talk a little bit more about the nature of the mutation having clinically important predictive value. So in diagnosis of PK deficiency, we really have a couple main options. The first is a diagnosis via PK enzyme activity. Now, this is typically used as the screening test, with genetic testing or exon sequencing done as the confirmatory test. Now, there are issues with both of these modalities. So with pyruvate kinase enzyme activity assessment, recent transfusion will interfere with the accuracy of the measurement. Also, PK, pyruvate kinase, is an age-dependent red cell enzyme, and patients with PK deficiency very frequently have very high reticulocyte counts. This is actually a really signature aspect of this disease, very, very, very high reticulocyte counts. And so if there's a significantly high proportion of immature red cells that you're evaluating, patients with true PK deficiency can come back with a PK enzyme assay in the normal range, typically at the lower end of the normal range. So one can improve upon this by doing a PK to HK ratio, a pyruvate kinase to hexakinase ratio. In a study we did, we found that this would, in 41 patients with PK deficiency, with molecularly confirmed PK deficiency, this was 98% sensitive, this ratio, which outperformed both PK enzyme activity as well as exon sequencing alone. Exon sequencing alone has about a 90% sensitivity, and that's because keeping true to the genetically highly heterogeneous nature of this disease, there are a number of deep intronic mutations that create aberrant splicing sites that are missed by exon sequencing. The pyruvate kinase deficiency peripheral blood smear really doesn't have anything pathognomonic necessarily to see. This is an example of a patient with PK deficiency. Their smear, and you can see a couple crenated echinocytes, these very small and sort of condensed echinocytes. Those can be seen in about half of patients with PK deficiency on their peripheral smear, but peripheral smear is not diagnostic in this disease. So when we talk about the advances, sort of the past, present, and future of PK deficiency, we must talk about the Pyruvate Kinase Deficiency Natural History Study, or NHS. This was a seminal paper, very, very important paper in the and our understanding, our current understanding of PK deficiency was only just published in 2018. So this was a study that enrolled 254 patients with molecularly confirmed pyruvate kinase deficiency. 28 sites internationally participated in this study. I could spend an entire talk going through the natural history study. I'll just go through some of the highlights. The prenatal or neonatal complication rate in patients with PK deficiency, there was a 28% perinatal complication rate, including preterm birth, prenatal anemia requiring in utero transfusion, intrauterine growth restriction. Even hydrops fetalis can be seen in patients with very severe pyruvate kinase deficiency and fetuses with very severe disease. 93% of patients, babies, were treated with phototherapy, and 46% required exchange transfusion. In childhood and adulthood, chronic anemia is the most common symptom of this disease. Of course, is a hereditary hemolytic anemia. 45% of patients reported having gallstones. 59% were splenectomized. Red cell transfusion requirements were highly variable, ranged between 1 lifetime transfusion and 516 lifetime transfusions with a median of 18. So other complications, less common but important, extramedullary hematopoiesis, which can be hepatosplenic, it can be paraspinous, which in patients for whom the diagnosis is not recognized, this can be very frightening for people, mistaking a paraspinal mass for potential malignancy. Extramedullary hematopoiesis can also be mediastinal. A small minority of patients develop pulmonary hypertension, but this is a very, very, very significant complication with dramatic implications for quality of life. Patients can develop leg ulcers, aplastic crises, especially with a parvoviral infection and certain other viruses. Patients develop iron overload, of course, and can develop cirrhosis and hepatocellular carcinoma as a consequence of that. Bone fracture was seen in 17% of patients. So it's very, very important to recognize, like thalassemia, patients with pyruvate kinase deficiency have an expanded erythron, expansion of their bone marrow hematopoietic compartment, which results in reduced bone density, often at very young ages. And I'm going to show you some data on that here shortly. 5% of patients develop endocrine disruption, dysfunction, which can come in all kinds. It can be iron overload related, thyroid disease, growth hormone deficiency, hypopituitarism, and so on and so forth. This is a figure showing extramedullary hematopoiesis in a patient with pyruvate kinase deficiency. You can see a very large paraspinal mass. Because patients with PK deficiency are sometimes, the diagnosis can be missed because it's not a disease that is recognized by all physicians. Patients can enter adulthood with an unexplained hemolytic anemia, as well as have some symptom or have some scan for some other reason. An extramedullary hematopoietic mass is seen on the scan, and it's not recognized that it's truly EMH and not some kind of tumor or malignancy. So osteopenia and osteoporosis, as I mentioned, very common. In a study of 155 patients with pyruvate kinase deficiency who had DEXA screening, a bone density a specialized bone density X-ray screen DEXA, the majority of patients had DEXA T-scores in the osteopenic or osteoporotic range, 58% osteopenic range and 17% osteoporotic range. This was in stark contrast to the patient's medical histories, of which only about a third had a known diagnosis, suggesting that this is much more common than previously thought. So I described before the different kind of mutations. We classify patients as having missense mutations or non-missense mutations in this disease, and this has clinical relevance. So, this is from the pyruvate kinase deficiency natural history study. You can see that the hemoglobin, the median hemoglobin, is lower in patients with significantly lower in patients with non-missense genotypes versus patients with missense genotypes. The non-missense genotype falls in the middle. This is also true for iron overload, which is much worse in the non-missense patients. Those with non-missense mutations were much more likely to have had splenectomy and other complications. Health-related quality of life in pyruvate kinase deficiency is something that has really not been investigated until relatively recently. A sub-study we did from the natural history study evaluating 123 children, 131 adults with pyruvate kinase deficiency from 7 countries. Again, this is a sub-study of the NHS using accepted standardized health-related quality of life and fatigue measuring instruments, found that certain characteristics in patients were associated with reduced health-related quality of life and higher fatigue or higher fatigue. So in children, more severe anemia, a non-missense genotype, iron overload with a ferritin greater than 1,000 or requiring iron chelation, and the requirement for regular transfusions was associated with reduced health-related quality of life and or higher fatigue. In adults, older age, female gender, having been splenectomized, iron overload, receipt of regular transfusions, and pulmonary hypertension were associated with reduced health-related quality of life and or higher fatigue. So, I'm going to spend the rest of the talk talking about treatment. Like many hereditary hemolytic anemias, patients with pyruvate kinase deficiency receive chronic transfusions or can receive chronic transfusions and can also receive intermittent transfusions. Some patients with pyruvate kinase deficiency can make it through without receiving any transfusions if they have relatively mild disease and or have managed to avoid having many hemolytic crises due to stressors like infection or pregnancy. Chronic transfusions in pyruvate kinase deficiency are given really without any guidelines. We don't have treatment guidelines for this disease, unfortunately, not yet. We transfuse patients with PK deficiency really on the basis of their symptoms, less so to a specific hemoglobin. It's been pretty well described in this disease that the severity of anemia does not necessarily correlate with the severity of clinical symptoms. This is something that, we don't want to exacerbate iron overload, which happens regardless of transfusions, but certainly is worse with transfusions. Splenectomy is, a very important treatment modality in pyruvate kinase deficiency, and historically has been the primary, potentially disease-impacting treatment modality. Splenectomy results in a hemoglobin rise of about 1 to 2 grams per deciliter in those patients that it works for. Splenectomy, tends to work to improve transfusion burden in most patients who are transfusion dependent. And can raise the hemoglobin in about half of cases. It's typically the use of splenectomy is somewhat controversial, and it depends on the country that you're in, and the population you're talking about. It's considered for all patients, especially if they have severe disease, but certain countries it's more common, and other countries it's less common. Personally, I try to avoid splenectomy in patients with PK deficiency if I can. I'm an adult hematologist by the time they get to me. Usually the decision has been made by their pediatrician, although I make the diagnosis of PK deficiency in a not insignificant number of adult patients. Most of the time we're able to keep their spleen in. Partial splenectomy has been tried. It doesn't really work. Hematopoietic stem cell transplant is a potential treatment modality in pyruvate kinase deficiency. There was a case series published recently of 16 patients that had with reported hematopoietic stem cell transplant for severe PKD. The outcomes were variable. A number of patients in this series had died of graft versus host disease. And so this is really something that should be reserved for the most severe cases, because we recognize that we are trading one chronic disease for another when we do an allogeneic hematopoietic stem cell transplant. I like, vintage tables, and I also like vintage figures. This is an example of a splenectomy, hemoglobin pre and post, as well as reticulocytes pre and post in a cohort of patients with PK deficiency. The black dots are pre and the white dots are post. And you can see that for those patients with both pre and post measurements, the hemoglobin can improve modestly or a little bit more significantly in a few patients. And the reticulocyte counts actually shoot up in this disease post-splenectomy. So like with thalassemia and sickle cell disease, there are important supportive care measures that we recommend for patients with pyruvate kinase deficiency. Every patient with PK deficiency should be on folic acid supplementation. For those patients that undergo splenectomy, obviously they should have immunization to protect against sepsis from encapsulated organisms. We recommend the annual influenza vaccine. Now we're recommending the COVID-19 vaccine, recognizing that the threat of acute viral illness causing a dramatic crash in the patient's hemoglobin and increased hemolysis is a very real problem. We want to avoid this with any virus that we can with vaccines. We are very big on surveillance, prevention, and management of iron overload. As with patients with thalassemia, we monitor iron in liver and pancreas and cardia and the heart. We will chelate as appropriate. Many of the guidelines in thalassemia are extrapolated to patients with pyruvate kinase deficiency in terms of our thresholds for initiation of chelation. We also surveil, attempt to prevent and manage osteopenia and osteoporosis, and encourage calcium and vitamin D supplementation in patients with PK deficiency, as well as other measures to preserve bone density and improve it. For patients who develop bone density issues, they should be treated for that like any other patient with osteopenia or osteoporosis. So now I'm going to finish off by talking about some therapies in development. The first and the one I'm going to talk about the most here is the pyruvate kinase activator mitapivat. So mitapivat is an investigational first-in-class oral allosteric activator of pyruvate kinase. It's a potent activator of both wild type and a wide range of mutant PKR enzymes. It binds allosterically to the PKR tetramer, enhancing affinity for its substrate, phosphoenolpyruvate, and this increases ATP production in the red cell. This is the first targeted therapy that addresses the underlying defect that leads to hemolysis in pyruvate kinase deficiency. This is the structure. It's a small molecule agent. In a phase 1 study of 48 healthy volunteers that received mitapivat or placebo for 14 days, there were no significant adverse events, and the optimal doses of mitapivat were defined. In a phase 2 study called the DRIVE PK study, this study assessed efficacy and safety of mitapivat in 52 patients with pyruvate kinase deficiency, found a mean peak hemoglobin rise of 3.4 grams per deciliter, and 50% of patients in the study met the secondary endpoint of a hemoglobin increase of greater than 1 gram per deciliter. The primary endpoint was safety in this phase 2 study. Most common side effects were headache, insomnia, nausea, common cold, arthralgia. Overall, the drug was quite well tolerated. There was an improved effect noted in patients with more missense mutations. So 2 missense mutations or missense and non-missense mutation did better than patients with 2 non-missense mutations. This is with the exception of R479H, the mutation found in the Pennsylvania Amish community, which is a missense mutation. This figure shows the change from baseline in hemoglobin level according to PKLR genotype. And you can see that patients in the dark blue with 2 missense mutations had a much higher likelihood of responding, although some of the patients with 2 missense mutations did not respond, as you can see. And then patients with at least 1 missense mutation also could respond quite well, but none of the patients with 2 non-missense mutations met the efficacy endpoint, the secondary efficacy endpoint of 1 gram per deciliter improvement in hemoglobin or greater. The hemoglobin response seen in the DRIVE-PK study was highly correlated, as one would expect, with the PKR protein level at baseline. So the more PKR protein to work with, the more you can potentially rev up that protein and improve ATP production, thereby reducing hemolysis and improving hemoglobin. The other, in addition to hemoglobin improvement shown in panel A here, you can also see improvements in reticulocyte count, indirect bilirubin, haptoglobin. All of these markers of hemolysis improved with treatment with mitapivat in patients who had a hemoglobin response, and they did not improve as much in patients that did not meet that hemoglobin response threshold. So everything moving in the direction one would expect. In a later sub-analysis of DRIVE-PK in the patients that had received mitapivat for greater than 12 months and had on-treatment DEXA monitoring, this protocol and the extension phase calls for regular on-treatment DEXA monitoring to assess bone mineral density. To follow it, because one of the main reasons for this, in addition to just understanding what happens to patients receiving mitapivat, if that potentially improves bone mineral density via reduction in the erythron expansion and bone marrow expansion from reduced hemolysis, mitapivat's also a mild aromatase inhibitor, and so it's important to make sure that there is not any problems with aromatase inhibition leading to reduced bone mineral density. And this figure on the left, the spaghetti plot, shows bone mineral density over time. You can see that generally most of the patients have a straight line. When we look at the patients that started with normal bone mineral density, all 12 of them receiving treatment with mitapivat for a year or longer still had normal bone mineral density. Patients that started osteopenic, 3 had improved to normal bone mineral density, 9 remained in the osteopenic range, and 1 had worsened to osteoporosis. And then for patients starting with osteoporosis at the beginning of the study, 1 improved to the osteopenic range and 4 remained in the osteoporotic range. So overall stability in BMD and patients receiving mitapivat. Moving on to the phase 3 studies. So Activate was a phase 3 global randomized double-blind placebo-controlled study of 80 patients with pyruvate kinase deficiency who did not receive regular transfusions. You can see the treatment schematic here, where patients that were screened and found to be eligible were then entered into a dose escalation period, individualized dose escalation period for either mitapivat or placebo. And then once they were on their optimized dose, they continued on that for 12 weeks in the fixed dose period, dose escalation period of 12 weeks, fixed dose period of 12 weeks. Notable, this study excluded patients who had 2 non-missense mutations or had 2 of the R479H Amish mutation for whom the drug was not shown to be effective in the DRIVE-PK study. This study met the primary endpoint, which was a sustained hemoglobin response of greater than or equal to 1.5 grams per deciliter. The 40% of patients receiving mitapivat met this primary endpoint versus 0% of patients receiving placebo. All the secondary efficacy endpoints were met, which included change from baseline in hemoglobin concentration, indirect bilirubin reticulocyte percentage, as well as improvement in patient-reported outcomes and markers of hemolysis. So this study employed 2 novel patient-reported outcome instruments called the PK Deficiency Diary and the PKD Impact Assessment. These were internally validated in the study The patients receiving mitapivat had significant improvements in these over the patients receiving placebo. All of these parameters, the improvements were durable over time in the study, and the drug was very well tolerated with a safety profile comparable to placebo. Again, this is just showing the blue here is the mitapivat arm, and the gray is the placebo arm. And remember, the first 12 weeks are a dose escalation period, finding that optimal dose. You can see hemoglobin improved and haptoglobin improved nicely. Indirect bilirubin and LDH both went down in accordance with the improvements in hemoglobin and haptoglobin. Activate-T was a partner study for Activate. This was a phase 3 global open label study of 27 patients with PKD who were receiving regular transfusions. And you can see somewhat of a similar schematic, although important differences. Obviously, this is not a randomized study. Patients had a similar dose escalation period, which lasted up to 16 weeks, and then a fixed dose period for 24 weeks. Similar exclusion based on genotype. This study met its primary endpoint as well, with 37% of patients achieving a 33% or greater reduction in transfusion burden, and mitapivat overall was well tolerated. Lastly, I just want to briefly mention gene therapy. So there is a clinical trial open right now for gene therapy from Rocket. This is a lentiviral mediated gene therapy product currently in phase 1. This involves myeloablative conditioning followed by infusion of the gene therapy product. The study is to enroll 6 subjects with severe pyruvate kinase deficiency. At ASH, they described the results of the first subject, a 31-year-old woman who had rather substantial improvement in all of her disease-related complications and her anemia. So looking forward to hearing more from this as well. To finish off my talk, I obviously want to thank the Thalassemia International Federation for this invitation and for having this important PKD symposium. Obviously want to thank the patients with PKD participating in clinical trials to improve the treatments and the lives of patients with PKD everywhere, the PKD deficiency community, and I know we're going to hear from representatives of that community here at the symposium today, as well as my fellow investigators in PKD clinical trials, all the investigators in the Drive PK, Activate, and Activate-T studies, and others. So thanks, everyone.
Thank you, Hani. It's really interesting and lots to take away there. I think for me, one of the really interesting fact is the fact that reticulocytes rise naturally after splenectomy. I didn't know. So no matter how many of these conferences you attend, etc., we always learn something new all the time. And that was really interesting. And we will be taking questions at the end of the session. So please pop your questions in, and we'll be having a panel discussion at the end of the session. So that'll be your time to ask us what you'd like to find out about. So we move on now. As Hani mentioned, we have a reasonably large PK deficiency community. Much of it is online. Our next speaker is Micah Akenram, who actually I met a few weeks ago, having known each other for about 4 years. She and her partner came over to London, which is pretty amazing to, having lived, I'm now 51, I suppose in the last 5 years, I've got to know a few people with PKD. Before that, it was quite an isolated world for me, and I guess it is for others. So to have this opportunity today to talk to colleagues is amazing. So thank you again to Tiff. So we'll now hear from Micah about the patient perspective.
Thank you very much for this introduction, and thank you very much for inviting me to this TIFF 21 conference. I was asked to do a presentation about living with pyruvate kinase deficiency through the years, the patient perspective. And I'd like to introduce myself first. My name is Micah Akenram. I am 47 years old and I come from the Netherlands. I was born in a family with 3 children, and both my sister and I have PKD, and I am a proud mother of 2 almost grown big boys at the moment, and I am a partner of Robert, who also has PKD, and we met on a conference about 6-7 years ago, and so it's I know PKD from living with my partner and with my sister and myself, obviously. So why am I here? I'd like to explain a bit more about PKD, and I'd like to do that explaining it in 3 different ways, with the physical aspects, the social aspects, and the mental health aspects of PKD. So first of all, the physical aspects, the most talked about in the medical world, I think. So in my case, my HB was kept very low. I was kept on a HB of 3.5 millimole per liter. And the idea was to have less transfusions, which was better for my body and would be also better to not have so much iron in my body. When I was 2, I had a splenectomy, and that made all the difference. In the beginning, I was every 6 weeks having a transfusions, and after the splenectomy, it was every three times a year or something. But that, because I was kept so low, it also meant that it always was sort of a stressful thing to go to the hospital. I was ill, my HB would drop quickly, therefore I had to emergency transfusion. So the memories I have of transfusions are always something about stress and panic. I was very jaundiced for a very long time, and of course that had lots of impacts on my, well, how I felt about myself. And around when I was 16, my jaundice became even worse, and they realized I had gallstones, and they removed it around when I was 16. I wasn't treated for iron overload until I was about 18 years old. By that time, I was a student living on my own, and I had to do the death row pumps, which of course I hated. And but my iron was very high despite having a low HB, and that's of course because we keep our iron high anyway because of PKD. Around my 30th, I started to develop lots of pain episodes, and these pain episodes were never really properly diagnosed. Doctors didn't really know what I had. They thought it might be fibromyalgia or something, and they didn't really give a diagnosis. But at one point I started to get transfusions every 3 weeks, and my HB was brought to 6 millimole per liter, and after that my pain disappeared. I didn't have much pain anymore, and my energy started to rise, and I also felt clearer in my head, and that I hadn't realized that could make such a difference. So what worked well for me? Well, splenectomy worked very well for me. The regular transfusions made so much difference in my life. Rehabilitation therapy I had around 30s something, and that made a difference in the idea that I could talk about it differently and I could accept things better, and I was able to learn techniques to spread my energy levels. And what is crucial in all of this is a good contact with my hematologist, and I think that's very important for everyone. So then the social aspects of pyruvate kinase deficiency. The first thing I want to mention is the attachment. Because I was ill and I was in a very old-fashioned hospital, I was put in a little bed for 4 weeks on my own. So my parents weren't there, nurses weren't touching me at all, hardly. And so that had an impact on my attachment. Also, because after that, I went to the hospital quite a lot in the first 2 years. And on top of that, my parents were so stressed and they were survival mode because there was so much going on that the attachment and bonding had a real knock-on because of that. And it wasn't just me, of course. My siblings had the same kind of problem. Even though my brother wasn't ill, he was living with 2 ill children. So there was so much going on in the house. Because I was jaundiced, I was bullied at school. And because, you know, children are not very nice to people that are different. And I had lots of problems with that until I was about 13, 14 years old. I studied, I had a job, I became a mother, and I had a social life, and all went sort of well until I was sort of 35, as I said before. At that point, my health started to deteriorate. I got lots of pains and I was unable to do loads of these things. So that had an effect on my social life, on my work. I lost my job, and also on my motherhood, because again, I was the one now who was stressed and tired, and so that had an effect on my children again. So what would have been helpful? Become aware and open about limitations, and also about your possibility. My mantra was always, I'm very normal, treat me as I am normal. And of course I wasn't. And I think that's a lesson I've learned the hard way. And I learned that, as I said before, through rehabilitation therapy, for instance. It would have helped me to have support from school and hospitals throughout childhood. So how to deal with bullying, how to deal with being so tired, to really understand what it means to be ill. Support for the family, siblings, parents, they all have to deal with this, and it would be crucial to deal with that. And health coach connected to the hospital, where you can sort of see different ways and to deal with it, to find different answers. A hematologist can't do that all. You can't blame a doctor not to be able to do that. And it would be very helpful if there's someone else you could talk to. And find out what you love to do. I mean, that's of course very, very important too. And in my case, it's singing and gardening and cooking. And I love to do all these things. Pyruvate kinase deficiency has also an effect on mental health. And I want to name 3 of them that I think is important. The first one is trauma through hospital treatments, especially in the 60s, 70s, and 80s, and also the 90s. There was not a lot of attention about the mental health in that. So children were not really told very much in some of the hospitals still what was happening, and that created a loss of control, a loss of feeling control of our body, but also the situation. And for now, I still have a feeling of that in sort of flashbacks of what happened when I was a child. The other thing, as I said before, is the unsafe bonding. And of course, that was mainly in the 60s, 70s, and 80s. And also before, but then later on that changed because they had more idea of that. However, the stress in parents still cause that parents are not always aware of the suffering of a child, which you can't blame the parents, but it's good to have a understanding in that. And the illness-induced trauma, the trust in our bodies is crucial, and we keep on having to think about, is our body able to function now? Can we do this? Is it okay? Etc., etc. So what could be helpful? More control towards children in hospital, and give them more possibilities and information. Psychological support for parents and children. Specialist medical psychologists as part of the treatments. Again, to understand what's going on in your body and how to deal with things. In my case, yoga and mindfulness and walking really helped. And for other people, might be sports or any other hobby that would help for them. And contact with other patients and parents. For me, that was very important. And many of us have said, I never met anyone with PKD. I wished I knew someone. And you just have a conversation. That's just important. So in summary, PKD has effect on my physical, social, and mental health throughout my life. Being chronically ill is not just affecting the person, but also their surrounding. And by being aware of this really helped me change for the better. So thank you very much for your attention. I am looking forward to the other presentations, and if you have any questions, I'd love to answer any questions you have. So thank you very much.
Thank you, Micah.
Thank you, Micah, for that wonderful presentation and for sharing so many personal aspects of your journey with pyruvate kinase deficiency throughout your life.
So we move next to Dr. Ava, who's going to be talking to us about the rare genetic disease that affects red blood cells. Dr. Ava, thank you.
Hello, dear all. I'm Professor Stefan Eber from Munich, Germany, and I'm very happy to contribute to TIFF Conference 2021. And I would like to speak about pyruvate kinase deficiency, a rare genetic disease that affects red blood cell. Thank you for giving me the chance to contribute to your wonderful meeting. I'm running a praxis for pediatric and adolescent medicine, hematology, and tumor diagnostics. And I'm in charge of many patients with thalassemia, sickle cell disease, and other hematologic diseases. As you know, this educational program is sponsored by Agios, and I'm presenting on behalf of the company. So this information is just meant for you as parents, as scientists, as medical caregivers, and I hope we can contribute to your knowledge in this special disease. What is the aim of our talk today? At the conclusion of this presentation, you will learn what pyruvate kinase deficiency is, what causes pyruvate kinase deficiency, and whom it affects. You will know the spectrum of symptoms as well as the potential complications of PK deficiency. And I hope that I will demonstrate the impact of PK deficiency. Now, what is the role of red blood cells in the body? Red blood cells are produced by the bone marrow and are responsible for carrying and delivering oxygen throughout the body. For that reason, they contain hemoglobin, that is a protein molecule in red blood cells that carries oxygen from the lungs to the rest of the body. Well, now you see the figure in this slide, and you see how hemoglobin binds the blue demonstrated oxygen. Then the oxygen is just incorporated in the red cell and is carried from the lung to the rest of the body. And on the right side of this slide, you see the release of oxygen to all tissues, to heart, to lung, to abdominal, intestinal tract, to brain. Brain takes most of our oxygen, hopefully, that makes us as a mankind. So this is very important for us. How does PK deficiency affect red blood cell? Well, red blood cells make energy exclusively by converting glucose, that is a sugar, into ATP, that means energy. By that, red blood cells are some rest cells because they lost most of energy gaining metabolism and solely rely on glucose. That means that pyruvate kinase is an enzyme that is needed to convert glucose into ATP. And if you don't have PK, then you cannot make energy. Healthy red blood cells have enough ATP or energy made by the PK enzyme to survive the trip to deliver oxygen throughout the body. Red blood cells that do not have enough PK or lack the properly working PK have less ATP. So these red blood cells have less energy to do their job and as a result break apart more quickly. See at the right side to the figure. Well, you see here's the red blood cell which take up glucose, and by means of pyruvate kinase, that is the blue globule in the midst, it makes ATP and makes some byproduct of ATP creation in the upper section of the figure. Now, PK deficient red blood cells, they have a damaged blue and red mutated PK, and so they can only make, you see it in the bottom line, very tiny amounts of ATP, and of course the byproduct of ATP creation is also lower. Now, what is the breakdown of red blood cells? What causes hemolysis? Hemolysis means destroying blood. It's a Greek word, so what is the cause of the breakdown? Breakdown of hemolysis, breakdown called hemolysis, leads to low red blood cell count or low hemoglobin level. In patients with PK deficiency, red blood cells break down faster than they are made. The low level of hemoglobin or low red blood cell counts can cause chronic hemolytic anemia. That means less blood for whole life. Normally, after 120 days, red blood cells break down and are removed from circulation by the spleen. However, PK deficient red blood cells only last a few days to weeks. This continual process of frequent red blood cell breakdown is responsible for many of the symptom patients with PK deficiency experience. Let's look now to the figure. We have the red bone marrow. There are formed the red blood cell with a lifespan of 120 days, and these cells are destroyed in the spleen. And with PK deficiency, more cells are destroyed in the spleen. So, did you know red blood cell lifespan is shortened to a few days to weeks in people with PK deficiency? Now, how is PK deficiency inherited? The PKLR gene, a terrible word, pyruvate kinase liver red blood cell gene, gives the body instructions to make pyruvate kinase. So everyone inherits 2 copies of the PKLR gene, one from each parent. And that means that PK deficiency is an autosomal recessive genetic disease. Because to inherit PK deficiency, you have to receive 2 non-working copies of the PKLR gene. Most people inherit a different PKLR mutation from each of their parents. A mutation results when the sequence of a gene changes, resulting in a variant form. Just for those who are not familiar with gene mutations, you know that all our informations are in the so-called DNA, and if you change the DNA, then you have a mutation, as I described in the PK deficiency. So let's go to the figure. The father has 1 non-working PKLR gene, he's a carrier. The mother has 1 non-working PKLR gene, she's a carrier. So both parents are not affected. So statistically, one of their children, 1/4 of the children, is severely affected without no or non-well-working PK protein. Statistically, 2 children are carrier and 1 child statistically is healthy. Of course, the casual has no remembrance, so it might be that they have 4 children with PK deficiency or non-children with PK deficiency. Okay, let's go further on. If I have a PK deficiency will my children have it too? Well, as I described, yes. If my partner has also PK deficiency, then it might be that the children are affected. If I'm affected and my partner is not affected, it is very unlikely that the children will have PK deficiency. That is more likely that all children will be carriers of the defect. Only if these children marry another person, this person should be checked for being a carrier of PK deficiency in order to know if a child will be born with PK deficiency. Now, what are the signs and symptoms of PK deficiency? Symptoms are different for everyone and can change over time. Common symptoms include fatigue, reduced ability to perform physical activity, jaundice, that means yellowing of skin, scleral icterus, that means yellowing of the whites of the eyes, shortness of breath, headache, abdominal pain, bone pain, difficulty in concentrating, brain fog, that means, well, sometimes I feel dizzy, sometimes I really can't think as well as the others, maybe even memory loss. And our patient, our lady here, which is affected by PK deficiency, says there are different points in your life where it's harder versus other times where it's easier. That's important to know. Your children might experience exactly what is Tamara saying. So how does chronic hemolysis affect the body? By three processes: a lack of healthy red blood cell, the breakdown of red blood cell, and the removal of red blood cells. Let's go through this figure. The lower amounts of red blood cells reduce the amount of oxygen in the body, causing stress on the heart and lungs that can lead to tiredness and fatigue, to headaches, to shortness of breath, to inability to exercise, cognitive difficulties, aplastic crisis, all what Tamara was just telling us. Then comes the breakdown of red blood cells and release of bilirubin into the bloodstream. Bilirubin is just the trash of hemoglobin. If the body destroys hemoglobin, he makes bilirubin. Bilirubin causes yellowing of the skin and yellowing of the whites of the eye. Bilirubin may build up in the gallbladder, may build up and contribute to the formation of black gallstones. I just say black because due to the bilirubin, these gallstones are typically really black ones. It differentiates from all other gallstones. And the removal of the red blood cells, as the spleen removes old or damaged red blood cells, they may collect in that organ, causing an enlarged spleen. Working red blood cells may also be removed due to the increase of the spleen, leading to an increase in anemia. So that's like a circle of devil. I increase the spleen, my red blood cells are destroyed. I increase the spleen and more red blood cells are destroyed. A hallmark of PK deficiency is the iron overload. That is specifically to PK deficiency and resembles the thalassemia disease. Most other hemolytic anemias do not get the iron overload during the time. So iron overload specific for PK deficient hemolytic anemia is an excess of iron in the body. The body has no mechanisms to break down the iron found in red blood cells. We have no way to get rid of iron which we once intook through all our life. Maybe a little bit throwing down some intestinal mucosa, but that is very faint, and maybe for women losing some blood during the monthly bleeding, but no other possibility. Iron overload can be caused by frequent blood transfusion, but as I said, as a speciality of PK deficiency, even people who don't get regular transfusions can develop iron overload. Iron overload is such a risk for all patients with PK deficiency. You see in the slide, the liver can process normal levels of iron on the top, but the liver will be damaged and struggle if there is excess iron in the blood. So what are the complications of iron overload? Iron can collect in various organs in the body and lead to complications over time. Iron overload is monitored by testing the blood for ferritin once or twice per year to see how much iron is building up in the body. If ferritin levels exceed 500 or maybe 800 nanogram per milliliter, as we do in thalassemia patients, follow-up tests to check the liver and heart may be recommended, especially in adults and adolescents above 10 to 12 years of age. So let's look to the right side. Liver cirrhosis may be caused by iron overload scarring of the liver. Heart issues. Some patients develop iron overload in the heart. A less common complication is pulmonary hypertension, a type of high blood pressure that can affect arteries in the lungs and heart. It's a severe complication and it has to be recognized very early because it can hardly be treated once it's really apparent. Osteopenia, a decrease in bone mass or bone mineral density. In severe cases, it can progress to osteoporosis. And that is really the cause why about 1/3 of patients with PK deficiency really have osteoporosis, really has an increased portion of causal fractures. That means their their bones break by themselves. A very hard complication of PK deficiency specific for this special form of hemolytic anemia. And of course, iron will be deposited in the endocrine glands and cause hormonal problems such as hypothyroidism, that is adrenal gland problems, and some other problems. So iron overload can occur at any age with any hemoglobin levels, and all patients should be regularly monitored for iron overload at least once per year, definitely several times per year. What can we do to manage PK deficiency? Options that exist today are supported in nature and do not address the disease underlying cause. Some treatments can have different effects on your health or other aspects of your life. So red cell transfusions. To boost red cell levels, donated blood cells can be added to the bloodstream. Some people with PK deficiency may never have transfusion. Some may have them occasionally. Others may have them on a regular basis. The second pillar of therapy in PK deficiency is splenectomy. The spleen may become enlarged due to red blood cell breaking down in the spleen. The spleen also sometimes removes red blood cells that still work. A splenectomy may be considered to increase red blood cells to prevent further complications of the increased destruction. But to my experience, splenectomy also poses severe problems such as severe bacterial infections in the blood called sepsis, or increased problems with thrombosis after splenectomy that is peculiar to pyruvate kinase deficiency. Well, a little bit optimistic, transfusion typically takes 1 to 4 hours. That is right, only the donation of the blood. But if you consider coming to the doctor's office, coming to the hospital, and going and being prepared and coming one day before for the test of compatibility, well, I would say it's at least a half day to be transfused. So many possible complications of PK deficiency must be considered. How you choose to manage your PK deficiency, of course, is up to you and your hematologist to decide. Well, there's cholecystectomy. I think one should definitely remove the gallbladder if there are symptoms of gallstones, because there is a high risk of pancreatic affection, and that is really a risk for your life. So in case of any symptoms of gallstones, the gallbladder must be removed. Whether you do it beforehand to prevent the risk of gallstones is very controversial, and I don't want to remark on that. Gallstones can, of course, cause nausea, stomach pain, or other forms of gallbladder disease, and especially pancreatic complications, which is the most worst complication. Chelation therapy. To manage iron overload, a type of medicine called a chelation agent may be described. Gladfully, we have now chelation agents that can be taken orally, and that really makes it much easier to take this medication. Chelation agents bind with iron in the bloodstream to form a substance the body can remove more easily. Well, Molly, an affected lady, says, find somebody willing to listen to you, to treat you how to feel. Every person is different, definitely right. PK deficiency can affect more than just the body. Common mental health challenges, anxiety, depression, low self-esteem, social isolation are expressed by more than half of the patients. The ability of daily life can be affected, and it may be that even patients cannot live their life as they want and are dependent on anyone else's help. Well, Robin, a patient with PK deficiency, says, my parents got me into horses when I was 10. I couldn't do the swimming and the tennis and all the stuff that my sister did. The horses I could do, so I excelled at them. I gave me an outlet to not think about the bullying, the disease, and I was able to compete in an athletic event like other kids and do as well as them. Thank you, Robin, for sharing your experience about the disease. So symptoms and treatments of PK deficiency may have effects on mental health, but there are always ways to find support. When should I see my hematologist? You should visit your doctor annually or probably more frequently for routine monitoring and screening. If you want to make adjustment to your management plan, if you experience any one of the following: worsening fatigue or pallor, significant worsening of jaundice, new abdominal pain, worsening of new shortness of breath. Very important now, fever after splenectomy. This is an urgent medical issue, and I can only advise everyone who has got fever after splenectomy, go immediately and see your doctor. There might be a lethal sepsis after short hours, and any, of course, new symptoms. So I want to summarize. Red blood cell is a rare genetic disease that causes red blood cells to break apart easily. That means hemolysis. Symptoms are individualized and can vary over time for a single patient. PK deficiency is associated with complications that need monitoring, including the development of gallstones, iron overload, and low bone density. Common supportive treatments for PK deficiency include blood transfusions, removal of the spleen, splenectomy, and medications to remove excess iron from the blood, chelation therapy. I want to share with you that there might come new medications that might improve the life of patients with PK deficiency. So there is hope coming up. It's important to work closely with your hematologist to monitor PK deficiency and define a management plan that addresses your individual needs. I wish you and your family and all the audience all the best in a life as normal as possible. Thank you for your attendance.
All right. Well, thanks to Dr. Aber for that wonderful talk. Really a tour de force, moving through all the various manifestations and of pyruvate kinase deficiency and how we monitor them and address them. It's my pleasure now to introduce our next speaker, Alejandra Watson. Alejandra leads the newly formed Pyruvate Kinase Deficiency Foundation. We are extremely fortunate at this point in the history of pyruvate kinase deficiency to now have patient advocacy groups that are forming on behalf of patients who have PKD. This is something that has been really long overdue, and we will have two representatives from two new groups speaking today. The first will be Alejandra. It's my pleasure to introduce her.
Hello, my name is Alejandra Watson, and I am the co-founder and president of the Pyruvate Kinase Deficiency Foundation. But most importantly, I am the mother of 3 boys, with only one having PKD. In order to understand why I created this foundation in partnership with 3 other wonderful women, please allow me to explain my journey, starting from 17 years ago on November 8, 2004. A few hours after birth, my son Jonathan was admitted to NICU due to high levels of bilirubin and the rapid destruction of his red blood cells. A few days later, he received his first exchange transfusion, and a month after that, a bone marrow aspiration. Jonathan was diagnosed with pyruvate kinase deficiency in February of 2005 after a series of tests. The hematologist back then told me that my son was only going to live for a few more months. So I decided to learn more about the disease by looking for more people with pyruvate kinase deficiency. Almost 2 years afterwards, I finally found another patient in the Netherlands who later became the voice of my baby and the fierce advocate despite being only 15 years old at the time. Who could have guessed that the same teenager I met when Jonathan was a baby was going to be my partner in a much bigger way. Together, along with another teenager in 2009, the 3 of us founded a much needed support group in Facebook to help other patients, parents, and immediate family members cope and deal with pyruvate kinase deficiency. Throughout the years, I have learned that most patients with pyruvate kinase deficiency have complex issues, multiple symptoms, and variable presentations of the symptoms. In early childhood, Jonathan began to have frequent abdominal pain. The doctors were reluctant to intervene, so I had to argue with the doctors for an ultrasound, which showed that Jonathan was having gallstone, biliary sludge, and a large spleen. After additional arguing to have a combined spleen gallbladder removal, Jonathan's spleen was instead removed first, only for his gallbladder to be removed 3 months later. The surgery was complicated, and he ended up in ICU for a collapsed lung and incisional infection. Over time, we noted many different symptoms that may have been difficult to identify, like problems with his lungs, oxygen desaturation, hyper or hypoglycemia, congenital heart conditions, and chronic illnesses. Over the course of his life, Jonathan has had to undergo 14 surgical procedures. He has been able to live a fairly normal life, but has experienced many complications and setbacks. Living with PKD can isolate you from the world because the conventional treatments for PKD prevent kids, teenagers, young adults, and adults from living the life they want to, especially if you suffer from a severe form of PKD that requires regular blood transfusions. A lot of kids and teenagers don't like hanging out with other kids who cannot keep up with them and or don't share the same interest. Jonathan often might share the same interests as other teenagers and be able to keep up or even excel past them mentally, but he lacks the physical ability to keep up with them in games or sports. Jonathan has taught me that life is more than just your social status, having lots of friends, or feeling isolated or alone. He teaches me every day to see life in a more balanced and positive way, to enjoy the morning and the night, to believe in myself, and to stretch my hand out to reach the stars. Jonathan can be very sick one day, but his optimism in life and strength will lift him up the next and prepare him to be stronger for the next fight. Life hasn't been easy, but it has been full of wonderful experiences that have been helping us overcome the challenge of a life filled with pain and unexpected illnesses. Because of his enthusiasm, I have worked hard every day to finally achieve my goal to start a foundation and have the ability to help more parents like me and patients like him. The Pyruvate Kinase Deficiency Foundation finally rolled out on July 1st, 2021. Since then, we have received our 501c3 designation. Our foundation provides science-based education to patients, their caregivers, and the medical community. The Pyruvate Kinase Deficiency Foundation advocates on behalf of the PKD community for affordable and accessible treatment options. We also support rigorous research that advances the understanding and treatment of pyruvate kinase deficiency for patients of all ages, empowering healthy, long, and fulfilling lives. Although we are a US-based program focusing on national pyruvate kinase deficiency issues, we will not hesitate to offer our assistance to any patient anywhere in the world that needs it. And we look forward to working with all other organizations seeking to help our community. We are also trying to extend our patient advisory committee to include patients and caregivers from all parts of the world because we believe every voice matters. Our key objectives are developing programs that meet the medical, financial, psychosocial, and education concerns or needs of those affected by pyruvate kinase deficiency, offering educational and supporting materials through our website, provider database, newsletter, and brochures, providing a national database of healthcare professionals knowledgeable in pyruvate kinase deficiency, providing a resource list of physicians participating in clinical trials, information about opening trials, and any published study data, sponsoring education to assist medical professionals in establishing appropriate standardized diagnostic and treatment guidelines, sponsoring national and regional meetings, and supporting our research into the cause and management of pyruvate kinase deficiency. We invite you to go to our website at pkdf.org and browse through everything that we offer. If you do, please be sure to register with your email address so we can send you the latest news about events and opportunities to get involved. You may also fill out our contact form if you have any questions, thoughts, or ideas you would like to share with us. Thank you very much for listening, and thank you, Tiff, for taking care of the global pyruvate kinase deficiency community. We appreciate it and look forward for creating quality resources for you to add to your compendium. Thank you very much and have a wonderful day.
Thank you to Alejandra for that really interesting talk about the PKD Foundation in the States. Unfortunately, Alejandra can't be with us later on for the questions and answers, but I'm sure if you have particular questions for her, we can get them to her somehow and get an answer back. On the point of questions, we do have a quick Q&A button at the bottom of your screen. If you have any questions for us at the end, please pop them in the little chat box there and we'll work through them. We have seen some already. So we now move to speak with Tamara Shriver, who is from the Thrive PKD Foundation in the States. I declare an interest. I'm a director with them, and I've known Tamara for quite some time, and we do rather laughingly call ourselves PKD siblings. We're a similar age, fairly similar experiences, even though we live on different sides of a large body of water, do we not? So we'll hear from Tamara and see what her views are building a community for PKD patients.
I'd like to thank Tiff for inviting me to speak today on behalf of Thrive with Pyruvate Kinase Deficiency Organization. I'm the co-founder and president of the organization, and I feel honored to be representing them today. Thrive with PK Deficiency is a U.S. nonprofit organization with 501c3 status launched this year with international ties. We have 6 board of directors who have all been directly touched by PKD, either as patients, caregivers, close family members, and/or friends. We are currently working on the addition of a 7th board member who will serve as a liaison to the Amish community. Our board members represent a variety of ages from Generation X to millennials, a variety of hemoglobin, severity of diseases, treatment types, and personal beliefs. Our inspiration for starting this nonprofit was to build on the connection we had with each other. We want to expand that connection to other people, to consolidate the many existing resources already available in PKD, and to elevate our voice in the rare disease community. We believe our vision is to empower people with PK deficiency to live a more satisfied life, and we hope to connect the PKD community through treatment support, increased social awareness, and advocacy. This is an ally proposal for the development of an internationally recognized PK Deficiency Awareness Day. What is a rare hemolytic anemia is now gathering support across the world and through various channels. Now is the time to establish an International PK Deficiency Awareness Day. By our count, there's approximately 680 peer-reviewed articles published on PKD in humans on PubMed since 1945, with patient populations in the US, Canada, Brazil, UK, Europe, China, Saudi Arabia, Rwanda, India, Thailand, Iraq, Iran, Japan, and obviously many, many more. Based on what a small committee of us was able to determine, we know there's at least 2 pharmaceutical companies and 5 rare disease organizations providing direct support for PKD. There's 4 nonprofits recently developed or in the stages of developing a nonprofit focused on PKD. And there's at least 9 unique Facebook pages and several social media accounts on channels including Twitter, Instagram, Reddit, and YouTube supporting all of this. Clearly, through the internet, we're now able to connect and raise awareness of PKD within our own local communities, and yet this slide still only represents the actions of a few countries. Our purpose today is to invite all PKD allies across the world to unite in an effort to launch an International PKD Awareness Day. Our goal is to launch an International PKD Awareness Day in 2022 across the world with your help. Our hemolytic anemia disease sisters, sickle cell and thalassemia, both have International Awareness Days, as do other rare anemias like Fanconi's anemia and Diamond-Blackfan anemia. The climate is right to start our own disease awareness building day so that PK deficiency becomes as recognizable as sickle cell and thalassemia. If after 5 years of consistent worldwide messaging on a given day of the year by all of us involved in the community, our hematologist, general practitioner, and even our neighbor understand that PKD is a chronic anemia, we'll have successfully reached our goal. And if after 10 years, all people with PKD across the world are able to access affordable, personalized treatment for their disease severity, we'll most certainly have reached our goal. Now, considering 2022 is only 2 months away, how do we accomplish this goal? We'll have to move rapidly and gather volunteers, and we hope to develop a committee. We'll have to truly set up an international day where all of you come in. We've talked to a handful of allies so far, and we'd like to continue those conversations by inviting more to the table. Our next step, of course, is to develop a committee that works together to develop a framework for an annual awareness day. This includes ironing out the basics like agreeing upon a date, logo, and key messages. We'd like to emphasize the flexibility embedded in this proposal. Now, typically, awareness days are times that nonprofits hold fundraisers and events to support their causes. The idea is the product, which in this case will be the International Day date, logo, and message, could appear in conjunction with your own fundraiser and event, whether it's on the internet or it's community-based, along with the logos of your PKD organizations. And then perhaps in the future, as we grow larger, we could organize collaborative events, meet in person, or do things around the world together. But for now, we think this flexibility would be a good start. And finally, to ensure unity, consistent messaging, and access to information for allies, a website, www.pkddeficiencyday.org, has been set up and will go live November 22nd, 2021 to help with the organization. Now, after gathering the committee volunteers, the difficult work of determining the date of the actual day will need to happen. The date should have some significance to PKD. Some suggestions have already been made. Valentine's Day on February 14th, Rare Disease Day on February 28th, World Donate Blood Day, June 14th, or a date related to the publication of the first manuscript sometime between 1961 to 62. And sorry about the typo there. Now, keep in mind there are other rare anemia awareness days, and we wouldn't want to schedule our day on the same day as theirs just to be respectful of their awareness day. Now, developing a logo for an International PK Deficiency Day needs to be done sensitive to the history of other logos already in existence, as well as international sensibilities. Our suggestion is to use the PKD ribbon as the foundation for a logo. Our designer has suggested a palette based on turquoise and ruby with gray and white for accent. We have a few logo prototypes and we wanted to call for more ideas with a deadline of December 10th, 2021. The PKD Awareness Day Committee would review the top design ideas, which would then be cleaned by a designer and returned to the community to be voted on. The target date for the final logo is January 15th, 2022. Here's an example of how one ally and our designer worked together to develop these logos. The initial logo included the PKD ribbon with the message 1 in 20,000 and 3 lines of subtext. The cleaned logo, example A, is a fairly literal translation, while example B is an inspirational version of that logo. This is an opportunity for those who like designing to be involved in awareness campaign, and we invite all designers to submit logo ideas. To summarize, we want International PK Deficiency Day to be an international effort with representation across the globe. We need volunteers from organizations, patients, families, allies from around the world. The more people involved behind the scenes, the more satisfaction and acceptance once it's launched. We know it's going to start small, like an awareness day, but hopefully it'll grow to an awareness week or a month, and we need your help. Please look for information on www.pkdeficiencyday.org or contact me at tamarascriver@gmail.com. Thank you so much.
Wonderful. Thank you so much, Tamara, for that excellent presentation, and so many exciting things on the horizon in PKD and the PKD patient community. So Carl and I are now going to go through, we'll finish up the session here with a Q&A. Everybody here, all of the presenters should feel comfortable contributing to questions and answers. We can go ahead and get started. So I'll read one of the very first questions in here. This is from Maria. The comment is, a very moving patient journey. As a thalassemia intermediate patient, we have so many similarities, especially the osteoporosis. Question, does mitapivat improve DEXA score for PK deficiency and for thalassemia? So I'm happy to take that question, and certainly anybody else, and Dr. Aber, you can chime in as well if you'd like. But, one of the things we recognize about bone mineral density disease in pyruvate kinase deficiency and thalassemia is that it takes years, decades to develop. This is a chronic process, a slow chronic process whereby the reduction in bone mineral density is not really measured in the span of a few months, but rather measured in the span over years or even decades. The data, and I presented some of the data for mitapivat and pyruvate kinase deficiency as it relates to bone mineral density. The data so far is only for relatively short periods of time. So the data I presented was for a year. There's additional data that I'm going to be presenting at ASH, the American Society of Hematology annual meeting in December, that was just recently published online on the ASH website with a longer duration of up to 5 years. And so this is all with patients with pyruvate kinase deficiency. One of my colleagues, Dr. Kevin Kuo, is also publishing some of our data in thalassemia with mitapivat. Presenting on some of our data at ASH. The short answer is it's not clear yet, but we're seeing stability. And stability right now is a win because the expectation is a slow decline over time. And so recognizing that this process took decades to get the bone to the point it is, it may take a very long time for that bone to improve with targeted therapy in pyruvate kinase deficiency, as well as similar therapy in thalassemia. So it's something that we don't know just yet, but we recognize that it does have promise because it reduces the underlying cause of the reduced bone mineral density. It reduces that hemolysis and reduces the bone marrow drive to produce red blood cells, which is what causes one of the main causes of the reduced bone density in the first place. Also, if it improves the iron overload piece, which there's some data coming out now, again, from the studies of mitapivat that it may do so, that iron overload piece also is a very important contributor to the bone density issues, as well as chelation. So if we're able to really move physiology closer to normal and further away from the disordered state that it's in both thalassemia and PKD, we may be able to achieve significant improvements in bone density over time.
Dr. Aber, do you have anything you'd like to add to that?
Dr. Aber, I think you're muted. Okay, well, while we try to work out that technical issue with Dr. Aber's audio, we can go to another one of our questions here, and this one would be for Tamara. Dore says, now the ribbon that you presented now looks almost identical to the one for polycystic kidney disease, and that's a different PKD. So any thoughts in response to that comment?
Sure. We would definitely go back to look at the polycystic kidney disease to make sure that that's not the case. I think the one that we looked at is one that has been historically used in PKD. It is a turquoise ribbon that has little red, what look like blood cells on the legs of the ribbon. And so it wouldn't have to be that ribbon per se that we would use in the PKD, deficiency. What we're thinking about using for the actual logo would be an iteration of that, and we would love for you to be a part of that. Like, what do you think would be a good option? So if you have input, we would love to have you join that committee. If you have opinions.
Thank you. And actually, we have a question from, well, two questions actually from Tamara. I think, firstly, Hanny, if you could describe the future of PKD research, but also we heard yesterday around the genotype-phenotype symptoms of thalassemia and how to treat patients based on the phenotype. And do you think PKD treatments could get to that point as well? I mean, there's a whole kind of debate, isn't there, about do we look at the hemoglobin numbers or do we look at, the clinical condition of patients? And there's a whole array of answers, isn't there? It is a spectrum of responses, really. So those would be interested to hear your views.
Yeah, I thank you for the question. I think we will eventually get to this point. We're in a place right now where, for the first time, there are actually pharmaceuticals being developed for this disease. There's gene therapy in clinical trials for this disease. This was basically unthinkable about a decade ago for such a rare disease. So I think that we are going to, the data that has come out on all of these therapies in development thus far has been quite positive with, really convincing evidence for efficacy, not in every patient, and that's a problem, but in most patients, there's, visualized improvements on mitapivat. And then when we talk about gene therapy, the data that we have so far, again, it's in a very small number, but it's very, very promising. So I think we may get to a future where if we have both gene therapy and drug therapies available, we still have splenectomy and we still have transfusions and other things, but I think we'll get into a future where we'll be able to personalize treatment based on their phenotype, yes, based on how the severity of their disease, how much it impacts their life, how much the disease impacts their normal physiology. You could imagine a place where we have patients generally try drug therapy, and for those patients in whom drug therapy is highly effective, they take a pill each day and they move on with their lives. For patients in whom drug therapy doesn't work, who have very severe disease, you could imagine a place for gene therapy, including relatively young in life, to restore normal hematopoiesis and rid the patient of the hemolytic anemia in large part, or in essentially completion, depending on the ultimate efficacy of that gene therapy. So I do think that we are in an extremely exciting time and that things will continue to improve, yes.
Thank you.
My pleasure. Dr. Aber, do we have volume for you now? You're welcome to opine on that as well as the other question.
Do you hear me now? Can you?
We do.
Okay, thank you. There was a nice man from Athens helped me in this problem. I'm sorry for the inconvenience. Thank you. It's really a pleasure to see you all here united under the roof of PKD, and thank you for giving me the possibility to speak. I think osteoporosis is definitely one of the big problems of PKD patients. And so, Mr. Al-Samkari, I really can only agree with you. It's very important. Once the patient's got 40, 50 years, I have 2 to 3 patients which really suffered heavily from osteoporosis. And I think if anything, then mitapivat might contribute to arrest the progress of osteoporosis. Also, of course, if I can stop the transfusions, then I'm no longer in need of such a severe iron chelation. And we know quite well that iron chelation makes osteoporosis. So I agree with you. It's a very important point to stop the further progress of osteoporosis. Probably you cannot go back with the osteoporosis you once achieved, but it's important to stop it. And I think mitapivat really gives the chance to stop the further progress of iron chelation and hopefully stop the further progress of osteoporosis. I did not get the other question because I was on mute.
Well, that's okay. It was just that, the future of pyruvate kinase deficiency therapy, personalization of therapy for patients based on their phenotype, given potentially available treatment options.
Well, I think the audience is well aware of allosteric effector therapies. I hope that I got it out clearly. My inclination would be splenectomy is really a yes or not answer. You cannot go back once you did splenectomy. And so as we just published a paper on complication of splenectomy, showing a considerable high frequency of infections, of severe infections, showing a considerable high rate of thrombosis, which is my personal experience also, that there is a considerable thrombosis rate. I would be inclined to put the allosteric effector therapy ahead of splenectomy and try it for let's say 3 to 6 months. Because if it does not work, okay, then there's nothing happened. But if you do splenectomy, then you have done it and you cannot go back. So that would be my meaning, my opinion. In patients which would be appropriate for an allosteric effector therapy, or maybe even for a gene therapy, just to speak about that, it might be wise to put that ahead of splenectomy and put splenectomy afterwards. It's working splenectomy, that's right in most patients, but it has so many complications, especially in PKD. It has not so many complications in spherocytosis, but it has so many complications in PKD. So I would just make this change in the row of therapies. Thank you.
I couldn't agree more with you. I think, I have a number of patients with PKD and about half of them have had splenectomy. And the pyruvate kinase natural history study, which I presented some data from, there were no patients in that study that had not had a splenectomy that had a thrombosis. All of the patients that had thrombosis were post-splenectomy. And, one of my patients who's had a splenectomy has had such bad thromboembolic disease that it necessitated a major surgery to address her chronic thromboembolic disease. And so this is something that we, and she was post-splenectomy. And so this is something that I think, we're really understanding more and more the consequences of splenectomy and PKD, and hopefully with new therapies, we'll be able to avoid it in far more patients.
This is Tamara. Do we know why PKD patients are more likely to thrombose with splenectomy?
May I give an answer, Hani, or would you like? Well,
go ahead.
My opinion would be any disease which has an ongoing hemolysis after splenectomy is an increased risk of thrombosis. We know it by chance from stomatocytosis, which really enhanced frequency of thrombosis. But we know it also from other hemolytic disease. Autoimmune hemolytic disease after splenectomy has a very, very high risk of thrombosis. I lost a patient, I never forgot about that, in autoimmune hemolytic diseases. So any hemolytic anemia with ongoing hemolysis after splenectomy has increased risk of thrombosis. In PKD, I think it's a special theme. There are some microvesicles sharing annexin at the outer surface of the vesicle. And so these phosphatidyl serines and other lipids are very, very thrombogenic. And I think they are persisting in hemolytic and hence spherocytosis after splenectomy. Probably they are cleared before splenectomy by the spleen. But once you took it out, this microvesicle, which can be highly thrombogenic, would persist and increase the risk of thrombosis after splenectomy. From these 2 points, I think these patients are endangered by thrombosis.
Thank you.
Wonderful. We have a question from Maike, but I think she's having some issues with her connection, so we'll wait, see if she pops back in. Oh, she's here. Okay, great. Maike, how has your journey been impacted by having 2 pyruvate kinase deficiency patients in your family growing up?
I don't know if you can hear me. My connection.
We can.
Okay, thank you. That's good. Well, I only had my sister and me. How is it affected? Well, I think that's a very difficult one because it's quite clear that no PKD patient is the same. So, you know, we're all very different. So you assume that when you have a sister with PKD, that's, you know exactly what the other one is going through, but that's absolutely not the case. I was very different than her, a different person. We had a different illness in a way. We were very different in how we were ill, how many times we were ill, how we dealt with our illness. And so that made me very quickly very aware that there is not one PKD. And as I said in my video, my partner has PKD. And you think, oh, well, then you know what that is, but it's absolutely not the case. We're very different again. So how does it impact me? Well, it made me, sometimes in the beginning, it made me very insecure because I thought I should be like the other people. I should just be like them. And I wasn't. So I thought less of myself. Growing up, I realized that's not the case. And we are very different. And I can see that now more. So that's, I think, how I dealt with it. I don't know if that answers the question a bit.
No, I think it does. I think, and please, I invite the other patients with PKD that are part of our discussion here to just discuss their experiences as well. I mean, I've always felt, when I'm discussing this with patients and really, frankly, with other doctors who don't have as much experience, I like to say every patient is their own person with this disease. It's very different from patient to patient. A lot of diseases can be very similar from patient to patient. This disease is remarkably different. And, I have over 24 patients with pyruvate kinase deficiency who I care for, and they are each completely different from the others. There are no 2 that are alike.
I would totally agree with that. I mean, the number of people that I speak to, we all have very different stories, even with the same disease. I mean, and I think for me, the other thing is that, and I think there's good evidence for this, that as you get older, the disease progresses and affects you, some people more than others. I know that some people, are diagnosed later in life because they're walking with their friends and they're a bit slower, a bit more breathless, and they might be in their 40s, 50s, 60s, can't they? So they've been quite late on in life. But my experience is, I had splenectomy when I was 7. That was kind of a routine thing. That was in 1977. And going back to the whole kind of the 1961 thing, I was a patient of Professor Gracie and Ted Gordon Smith at the Hammersmith, who kind of led on a great deal of this work. I'm still in touch with Ted Gordon-Smith these days. You know, the guy, I would say, is heroic in what he brought forward and the care he gave to a number of us. And I know a mother who has two children of my age with PK deficiency, and the care that we got then. I think, you know, I split out when I was 7. I had very few transfusions. I had a few aplastic episodes with viruses. And then in my 20s, I started to need more blood, and now I have weekly transfusions. And I'll ask a question in a moment as well about, you know, progression in people of my age versus people who will become older, who are kids now. But, you know, when I was in my late teens, early 20s, I was running 3 miles a night. I was swimming 90 lengths. I was cycling 50 miles. You know, and I wasn't transfused then. You know, my splenectomy worked amazingly well and gave me a reasonable hemoglobin. And but then as I got older, it's changed. So I think entirely that the whole progression of disease varies per person, and even, you know, we all have different HB burdens. You know, I'm transfused at the top of normal range just to give me the energy to keep going. So it's a hugely complicated issue, isn't it? And if I could throw my question, and that's, you know, the whole kind of Thrive thing is about, in essence, you know, and one of my biggest things is about supporting families with newly diagnosed children and adults sometimes, but particularly around children. And, you know, you get this healthy, bouncy baby that you expect, and then they're terribly ill and need lots of investigations and treatments. And my real hope is, and I do say to parents, that because we know how to care for people and we know the monitoring, etc., I think some of the life experiences that we are having, and Tamara doesn't mind me saying, you know, the disease burden that we now carry at our age, I'm really hopeful that that won't happen to young people of today when they get to our age. And Dr. Ava and Hanley, do you think that's a reasonable thing to say to parents, a false hope that we're giving them? Because I wouldn't want to give false hope, but I think it's reasonable to have a bit of a warning. You know, sometimes when we talk about our, you know, on Facebook groups, I always try and say, I'm a child of the 70s though, and we had amazing medical care for what was known at the time. I couldn't fault it, but it was a very different level of care to what's available now.
I don't think it's false hope at all. I think it's the right tone to be striking. It's not just because of therapies. Therapies are a big part of it, obviously new therapies, but it's also because of recognition, understanding, because of the work that people like Tamara and Alejandra are doing to develop foundations and patient advocacy groups for this disease. These things work synergistically to ensure a better future for people with it, you know, in the coming years versus, you know, someone like yourself, Carl, who, you know, 30, 40 years ago, there was so much less understanding and so much less data and so much less knowledge and so much less advocacy for the disease. And I think we should not underestimate the power of a new therapy in and forcing doctors all over the place to ensure that they are diagnosing patients correctly. I mentioned in my talk, I've diagnosed patients in their 60s with pyruvate kinase deficiency who have hemoglobins in the 8 or 9 range. I mean, nobody should get this diagnosis at age 60 because it was missed over and over throughout all the various illnesses of their life. If you don't know what it is, you don't know to look for it, and you can't diagnose it. And there being therapies that are actually disease modifying will mean that doctors the world over will look for the disease when they may not have looked for it before.
So I have a question for you. When you're diagnosing a patient in their 40s, 50s, 60s, I know this is unfair to ask, but are they generally more? I mean, I know even though I was diagnosed about 50 years ago, it was pretty severe. So something had to be determined in order for me to continue with life.
That's a good question. I wouldn't use the word mild, but they're not typically dependent on transfusions. So if a baby or a child is transfusion dependent, usually they'll get, you know, they'll continue to see people until somebody is able to diagnose them. But there are patients that are, you know, in the community, they're not very close to an academic center. They have a moderate anemia. You know, their hemoglobin is 9 or it's 10. They're otherwise okay. it's clear that they have hemolysis. Somebody's done a basic hemolysis workup that hasn't included looking for PKD or other enzymopathies. They say, well, it's none of these things, but you're fine. So, go about your life, and you have this chronic anemia. And they do that. And the problem is they show up at age 55 and they have a horrible liver iron overload and all sorts of problems. They have osteoporosis. They've had 2 bone fractures. They have, multiple, thyroid disease, all these issues because they were just sort of left kind of by the wayside. And that is an sort of an unforgivable thing. That's something that should no longer happen, should never have happened, but certainly should no longer happen. And I think that's a lot less likely. And I get they eventually get sent to me and I diagnose them. And that's, at least they get a diagnosis, better late than never. And we can start working on the iron and start working on everything. But, I think with the development of new therapies, this is going to be less of an issue. So Shabano asks, what are the diagnostic tests that need to be done to diagnose someone with PKD? I'm happy to take that question, but Dr. Aber, I don't want to do all the talking. Can you?
Thank you very much, Hani. To Carl, you see, I think it's not only the therapy of PKD itself. Think of the fatigue symptoms of patients with PKD. So the whole setting of treating fatigue with aids, with physiology, with physical therapy, with some efforts to diminish the lack of energy. So PKD is not only the hemolysis; it's the setting of complaints affecting the energy supply of the body. And I think there's really hope that we will cope with these complications much better than we did. Even if you don't profit from the new therapy, you will profit from the whole improvement of surrounding the disease, as I said, fatigue, as osteoporosis. So there's really some umbrella going up for PKD patients. Thank you for giving me a chance to speak on diagnosis. You see, I think the hallmark of diagnosis is still the measurements of residual enzyme activity. And you see, Hani is truly right. Tamara, to your question, you see, if this patient is continuously transfused, of course, his PK activity will be normal because I measure the activity in the transfused red cell. And even if he is not transfused regularly, then he has a high reticulocyte count. And reticulocytes have a 50-fold more PK activity than the normal erythrocytes. So patients with severe PK will have a seemingly normal activity. And if I don't relate that to the reticulocyte count, then I would not recognize the diminution of PK in this patient. So thankful to genetic diagnostic measurements, we can do the screening of the PK gene, and we will detect patients which are either have a high reticulocyte count and have no detectable PK deficiency as the enzyme measurements, or are transfused regularly, and then I cannot measure PK activity. In these patients, I would definitely do a genetic testing. A possible help for especially in children is measuring the parents. In PK, of course, both parents must be heterozygous carriers, and heterozygous carriers mostly are at the lower edge of PK normal activity, or a little bit below the lower edge of normal PK activity. So there are possibilities of pre-screening, and in cases you have a suspect of PK deficiency and are you not able to make a diagnosis by enzyme measurements, you should really do the genetic measure.
All right, so I'm taking a look at our time here, and it looks like we are running out. The hour is about over, so I'll go ahead and conclude things. First of all, I just want to thank all of the speakers and all of our panelists for what I think was a really enlightening, illuminating, and wonderful 2-hour symposium on pyruvate kinase deficiency, and hopefully the first of many such events to come. And we, as has been clearly discussed, this is a very exciting time in this disease. And I think we have bright times ahead. Carl, I want to turn it over to you for any concluding comments as well.
Well, I want to thank all of our speakers and yourself, Hanny, for co-chairing, and to everybody at TIFF for putting PKD on the map. It's been a kind of a hidden disease for many years. We've been nowhere in the limelight, and I think people who are creating new drugs for us are driving the agenda as well. And there is a huge amount of work going on to create communities. And hopefully, as part of my role with Thrive, is that we can link those up together around the world. And because there's so much resource going in, we don't want to waste a drop of resource. It's nearly as precious as blood, isn't it? And thank you to everybody. And I think also thank you, to people who donate blood for us. I think that's a huge thing to do, and has saved the lives of countless people, and made lives, particularly for us with PKD and people with thalassemia and sickle, actually possible. So yes, so thank you again to TIFF, and thank you to our audience for joining us this evening. I find it fascinating. I hope you have too. Thank you.
Wonderful. Thanks, everyone. With that, we'll adjourn.
Thank you.
All right.